Thank you, Jeremy, and it's a pleasure to be here. I think what I added to the group was a little bit of gray hair. They need a little bit of that. It's a pleasure to be here. I've been in Carolinas, at Carolinas Rehabilitation doing rehab urology, also urology, reconstruction, female pelvic medicine. And so what I thought I'd talk about this is really kind of the clinical aspects of research. I do consider myself a clinician, but I also really have enjoyed clinical research and also education. And so today I'll kind of review some of that. Throughout my time there, I've done hundreds of studies, a lot of them trying to bring things to development, and these are some of the current disclosures that I have. But when you look at research and what we're trying to do, it's always that bench to bedside. That's what you've kind of heard over the years. How can we take that transformational area? And really it strives from what are the unmet needs? What are the questions that you have? And it comes back down to the patient. And as a clinician, which most all of you are, you're really trying to improve the life of that patient. But when you really look at it from doing research on the bedside or at the bench, you can see it's an enormous time. Not only time, but there's a lot of money involvement that is energy spent to get to that. And this is kind of a cartoon here where you're seeing kind of the bench over at the bedside and the big chasm. And majority of things end up falling into the chasm because it really does take an enormous amount of time. So Dave showed this earlier. When you're looking at neurogenic bladder, we kind of focus on failure to store or failure to empty. And I think in neurogenic bladder, which I'll kind of focus on that area, is how can we improve upon that? And when you look at the current standard of care, failure to empty, I think we've really just done a disservice, or we need to really take it to the next level. When you look at how do we empty the bladder, there's really just a couple things. Intermittent catheterization, Dr. Lapides, fantastic innovation, has done well, but that's 1972. Foley catheter has been around for many, many years. Now we're starting to look towards neuromodulation, but there's still some questions on that, and that's to the future. So these limited treatment options we do need to improve. And as we've seen, when you're looking at it, you know what occurs? Urinary tract infections, urethral strictures, we get infections, epididymitis, you get other things such as bladder stones that occur. You can get bladder tumors, and Dave's right, for chronic SP2 Foley catheters, if you're in a place long enough, unfortunately, young people will develop bladder cancer. And oftentimes it's squamous cell, and it's gone beyond, and it's usually lethal. So surveillance, we need to kind of look at that. Catheter incrustation is prevalent. You'll be getting calls about that nonstop. What do you do? How do you prevent it? Irrigations. And then yes, this is the dreaded problem that you see. Traumatic urethral hypospadias from catheters being pulled and tugged, transfers, and so those tend to occur. Now, recently, about 3-4 years ago, you started noticing about catheter-associated urinary tract infections, CAUTIs. And the big thing is antibiotic resistance, so antibiotic stewardship, and all that is important. So that's really come to the limelight about catheters to be able to take those out. So if you look back, at least my time within 24 years at Carolinas, I've really looked to different things that can maybe bring things improved. And so we're going to hit on some of these innovations of some have failed along the way, some have done well. So let's first look at failure to empty. And let's look at kind of devices that go along that. I didn't know this had music to it, but it's a little adjustment. So 1997, I went to the AUA and I saw this fantastic device, this little Inflow device that you can see. It looked phenomenal. You know, you could place it in the urethra. It had little fins on that area. It set in place with an electromagnet. You could activate it. It would cause the turbine to spin, and boy, this would really eliminate the bladder. And it seemed very simple, that as it would cause that rotational force, the bladder would empty. You could, help people that didn't want to catheterize. For females that were, challenging to get on and off the commode. It was really something innovative, but once again, this is 20 years ago, 1997. The one thing that's unique about this is you saw it, it creates a turbine spin, so there's actually a vortex within the bladder to allow it to come out. In addition, it was so simple and easy that patients could take it out easily on their own. So I really, at that 1997, thought, wow, this has, this could meet a need. Now it's pretty large, it's 24 French, but it had different shaft lengths along that area. The flow rates that you had were very good, and it actually was easy to put in, easy to put out. So in 1997, we embarked upon a prospective, single-arm crossover study. We did it at several different centers, and really it was for people with impaired detrusor contractility, only women. Now the exclusion for what you said is atonic bladder. Now think back 20 years ago. I know for some of you that's far, but at that time we only had oxybutynin, and that's what we used. So we really made overactive bladders underactive by giving them anticholinergics. So they really weren't pure atonic bladders. You had to be mentally coherent, you can't have an MRI. So when we looked at it, what we were really looking at is the endpoint was, can it be equivalent to CIC? Can the PVRs be equal? In addition, we were looking at quality of life. Now, challenges, if you've done any studies, the way this study was set up is that you actually had an 8-week run-in phase, 8 weeks of CIC. And then after 2 months, you then started this putting the catheter in, and then you had that for an additional 4 months. Well, the trouble with that is people have never had this in their urethra before. If you've ever had contacts in your eyes, the first day it's like, oh, this is terrible, let me get it out. And so that's what they ran into. They said, wow, we've spent 2 months already, someone in a study, and within the first week they're having troubles and they drop out. So they amended the protocol and said, wait, we need a test phase. Let's do the first week CIC, the second week just try the device, test it, see if you kind of acclimate to it. And if that's the case, then we embark upon the study. So that screening phase. And as you see here, what tended to happen was that there was 61% dropout in that first phase. And then if you did the amended protocol, it was a 43% dropout. In total, we enrolled 157 patients, but you can see only 77 patients actually completed the protocol. But think back then, remember we had just oxybutynin, and these atonic bladders were probably overactive along with that. And certainly enough, the PVRs were equivalent. Most of them were less than 10 to 20 mLs left over. So the device was actually very, very effective at its primary goal. Quality of life for those 50% of people who could keep it in actually increased. But remember, quality of life, what tool is that? Was that the right measure? 20 years ago, that probably was all we had. When you looked at the adverse events, as you'd expect, adverse events were urinary leakage, pain, bladder infections, discomfort, dislodgement, a variety of something that's within the urethra. And so when they looked at the results that came through, certainly the device did empty the bladder adequately, but about 50% of women were dropping out from the trial. But you had to be motivated along that area to continue it, and those who did actually found it to be beneficial. Well, that device in 1997 when I went to the AUA was manufactured by Inflow. And Inflow then got bought by American Medical Systems. And then American Medical Systems got sort of bought again, and in year 2000, they shelved that. They basically withdrew the study. So this technology just stayed around for a while. It wasn't until about 6 years later that company SRS Medical decided to purchase this. They started looking into it, and they wanted to actually try to get this on the market, because some of the patients and some of mine that were using it loved it. So they actually moved it along, and they re-evaluated it. And when they looked at it, the one thing they noticed was, my gosh, when people had this device in, they had less bacteriuria and they had less urinary tract infections. Very intriguing along that. And in fact, when you looked at it, it was statistically significant that the UTI rates were lower. So they actually used that data, they went to the FDA, and finally, talking about 18 years later, in 2015, the FDA approved it mainly because of the decrease in UTIs. And the one thing that's interesting to know about is because of that sort of wheel and that sort of motor, you're actually spinning the bladder, and actually sort of any of that sediment and silt that's at the bottom that doesn't always drain when you catheterize, that may have some aspect to empty it. So with that, in 2015, it got FDA approval, but I stand here today and I bet most of you have never even seen this. Once again, it's because the challenge now of who's going to cover it, trying to get a CPT code for it. So when you look at catheters or devices, certainly it treats failure to empty, but there's a lot of drawbacks. You need to have mobility to get there. Can you truly have an atonic bladder? Now if you use a botulinum toxin, maybe that will be an advantage to it. But 20 years, finally, it's nice to see something moving along that it finally is going to come out, although we haven't really seen it yet. But that's just one aspect of what clinical research to get to the end. That company's not at the end yet. So this is a newer area. They said, well, what about the male? Well, let's look at the connected catheter system. So this is a little bit of different takeoff on it. An intraurethral catheter that has a catheter, sort of a turbine on it. It has a magnet. So it's a single catheter, but within the catheter there's eyelets at the end for drainage. There's a sort of retaining, dilating area that's going to be at the bulbous urethra. It's going to be 22 French. The catheter at the tip is actually 16 French that's in the bladder. There's no retaining balloon. The device is simply placed in with this instrument that you saw. It unlocks it. Once, there's 3 sizes of this device, so you'll have to do cystoscopy to make sure you get the right size. When you put the electromagnet on it, it will stimulate and the valve will open. Now this one doesn't have a turbine to drain it. This is actually going to be drained by gravity. Once it's drained by gravity, you'll then use the electromagnet again to sort of lock it in place. As with most all these, they're just 29-day or 28-day devices, so they're not permanent implants. That's mainly due to regulatory processing of things. But it's something that would be sort of in the office, easily to put in, and also easy to take out at that point in time. So when you take it out, you'll have the instrument tool that will go in, lock it in place. It's kind of a snare to be able to grab it and then slide it out. So this company right now is starting their sort of early phase of clinical work, and they're looking for adults over the age of 18 with neurogenic bladder. So kind of an interesting group to come up with. Obviously no urethral abnormalities, no strictures. And I think the challenges that this company will have, hopefully it won't take 20 years, but devices, I've done a lot of device work within the lower urinary tract. Always you're worried about infection, migration, you're worried about incrustation. What are the constituents of the urine going to be doing to it? Are people going to have anatomy differences? So these are all the things that, the challenges that these devices will come to. So let's look at something a little bit different. How many people here have heard of the Zhao procedure? So a few of you have. This actually started in China, and the Zhao procedure is for neurogenic bladder. It comes on the background of reflexes. So if you look at the patellar reflex, it hits the L5 area down the dorsal root, comes back out on the ventral root to cause contraction. But what they decided to do here was working on in cats, that if you took actually the L5 area and the S2 area after spinal cord injury, and you actually isolated those under the dura, you severed them, but what if you reanastomose it? So you put the L5 to the S2. And during that process, when you do that, you actually notice that you're actually going to start to get regrowth. Now it takes time for those nerves to come together. But when you get regrowth now, could you envision by scratching your thigh or causing a reflex that you actually stimulate the afferent area that then comes down to the efferent to cause a response for bladder contraction? Quite intuitive. And in fact, this was way back in the 1980s. They looked at animal models, and sure enough, in the cat model, they were able to at least show this within Japan. So kind of efferent neurons are able to trigger from the somatic reflex arc to the autonomic reflex arc. This was really quite innovative at that time. And in fact, Dr. Zhao in 2003 was like, whoa, 67% successful for spinal cord. Spina bifida, success rates in 85%. And then also for large, 110 spina bifida, 92 spinal cord, great success rates. Well, that generated a lot of noise and interest. And in fact, it generated interest because then you thought about this could be something life-changing for these type of patients with these conditions. Well, Dr. Ken Peters from Beaumont was looking at this, and he was very intrigued. He got a large donor to do a study for 9 spina bifida patients. He brought Dr. Zhao kind of on staff from China to help out, teach their neurosurgeons and Dr. Peters to work on this. And as you can see, they do a limited laminectomy, they open the dura, they identify the cauda equina, you actually identify the nerve roots of L5 and S3, you reanastomose them together. It takes roughly about 3 to 4 hours to do that, minimal blood loss. And only one person had sort of a lower extremity weakness. But as you're looking at it, the data that he wanted to look at was then how is the response? Well, 12 months later, you can see that 7 of the 12 people actually have a reflex arc stimulation. And that's kind of noted by the scratching of the leg. Will they have a contraction based on urodynamics? So not everyone has that. 12 months later, the bladder capacities really did not quite enlarge that much. But the one nice thing, as you'd expect, is that the contractions, the detrusor overactivity, kind of abated in majority of patients, and only 2 of them had detrusor overactivity. Compliance actually improved in 2/3 of them, but compliance actually was poor to a lot of these spina bifida patients to begin with. Now, all of them were able to stop their antimuscarinics, which is a nice aspect to it. But if you looked at the beginning, only 2 of the patients could void pre-treatment of about 27 mLs. After treatment, most all of them were voiding, but with voided volumes 156 mLs. As you follow these patients out, remember they're spina bifida. They have an open bladder neck. They basically, 6 out of 7 of them were leaking urine. So they still have incontinence to that area. You haven't really solved everything. In addition, at 36 months, majority of them weren't even using the scratch reflex. I don't know how they were actually voiding. You abated the hyperreflexia, but most of them having to do catheterization once a month. So the results that kind of came from this, at least in Dr. Peters' experience here in the US, and this is the only US, well, it's not the only US trial doing, is it was a little bit mixed. People had some improvement, others. There have been other studies that have been done in the pediatric area where they've kind of shown this hasn't worked out. So I think in general, certainly more trials will probably be needed. I think this patient population was different. They have an open bladder neck. They still have stress incontinence. They may do Valsalva chordae voiding that allows them to empty. And I think the enthusiasm that was with this trial is sort of gone down a little bit. So what about medications? How can you improve bladder emptying with medicines? Now, we know about overactive bladder. There's a plethora of OAB medicines, all the antimuscarinics, which there are about 7 of them. The beta-3 is something new. But why is it that we can't find a medicine to just contract the bladder? Bethanechol doesn't really work. But there is a medicine that's been studied, and it's DT100. It's basically a neurokinin A analog, specifically an NK2 agonist. And this actually has contractile or prokinetic activity on the smooth muscle. And in fact, when you use the IV, it occurs within 1 minute and then goes away within 10 minutes. So pretty fascinating. Could you imagine the spinal cord patient going to the restroom, sort of taking this in whatever form, under the tongue, a pill, a spray, having a bowel movement, having urination, out of the system within 5 minutes, wheeling out? That would be pretty amazing. And I think that's kind of what they're looking at. Well, they've done preclinical work with this compound, and they've shown that at least in vivo or vitro areas, they've shown on muscle you can get contraction. They also used an acute spinal cord injury, which you're seeing on the right here, that is a dose response. The higher you give the dose, you will get a bladder contraction. They've also shown it in chronic spinalized rats, and the same sort of effect. The company has moved along. They're now into phase 1, and they've treated 100 patients, not spinal cord, but 100, just to get the pharmacokinetic properties. And this study will be embarking on next for their phase 1 trial for spinal cord patients looking specifically at this. But I think this too will be a long road, but you may hear something about this in the future. Well, another area that's been of interest is regenerative medicine, autologous myocyte regenerative techniques. So this work has really been spearheaded mainly in the stress incontinence area. And we've been doing some of this work for a few years. But you basically are taking skeletal muscles, you then pre-plate them within the myocyte down to the actual stem cell. And the hope is that as you pre-populate that and expand it, and then re-inject it in, it will formulate a new muscle cell into the area that you're at. So the theory for underactive bladder, or a incomplete emptying, is sort of that technique in doing it. Now, the preclinical work that was here, which is quite amazing, you could understand it for stress incontinence because they're actually using skeletal muscle, precursor stem cell into skeletal muscle. But this was quite unique in that you actually could take skeletal muscle in the stem cell, re-inject it into the bladder, which is smooth muscle, and as you're noticing here, that alpha-SM actin that you're seeing in the green is actually a component of smooth muscle that they're seeing. In addition, when you looked at it, they started to see innervation starting to occur in this area, which is triggered by the acetylcholine kind of receptors that you're seeing. And then in the models that they've used, you actually, in the sham techniques and controls, you're seeing here based on the baseline, and then actually here, an improvement in bladder contractility after 1 week, which is pretty early time, because normally it takes a longer process. But that preclinical work basically allows the next phase. And this is already in sort of clinical arena right now, where you take a biopsy that's harvested from the skeletal muscle. Typically it's the femoris muscle that you're using, and we do this in the office. So it is under local anesthesia, just lidocaine. You place this in, you will get some good sort of techniques of learning how to core it out. It's like a wine opener. As you are opening the, I'll try and hurry up with time. As you're opening it up, you're able to pull out about 150 gram of the muscle, which you see small in this area here. And from there, you can sort of propagate the cells. It goes off into Pittsburgh, takes about 8 weeks to be able to propagate it. They bring it back in frozen, and then in the office, you'll do the injection. So this has been done under a compassionate use. This is up at Beaumont Hospital. Mike Chancellor has been doing this. The injection was on a man who had urinary retention. He's undergone prior TURPs. He's failed alpha blockers, bethanechol. They've injected it. 30 injections were done. 250 million cells were put in place. You can see the baseline, his maximum bladder capacity was 844. After 3 months, he was improved. These are probably modest results. They haven't really shown any further results from this, but there must have been enough, because now the FDA has a phase 2 trial looking at underactive bladder. And the programs that are doing are the Underactive Bladder Foundation. Cook Myocyte is the sponsor, and it's also still at Beaumont Hospital up in Detroit area. So I'll try to go quickly. I want to talk about kind of 2 other innovative things that are coming out on the flip side, sort of the failure to store. How do we treat that overactive bladder? Now we know from onabotulinum toxin A that has been out there from Allergan, that has really been a savior for a lot of us. But other ones they're working on now are abobotulinum toxin A, and that's going to be a little bit longer. But let's talk about now sort of how can you improve on a drug delivery type system. So I don't know if you've seen this system before, but this is a little drug delivery system here. It's about 5 centimeters, and the drug is within inside that area, and it's going to be intravesical. This was actually out in clinical trials mainly for interstitial cystitis, where they used 4% lidocaine for Hunner's ulcerations, and they actually showed it to be beneficial for Hunner's ulcerations, so subsequently the Allergan company purchased this. The company who really manufactures technology, Terrace Pharmaceuticals, actually still has the rights, and they've been using this for other things. If you're in the bladder cancer world, they're using gemcitabine for putting it in the bladder for bladder cancer. And in the OAB and neurogenic world, they're using trospium. So why would trospium be good? Because we've shown with trospium that you have increased urinary excretion. We've shown that the acetylcholine receptors in the urothelium can actually interact with this. Trospium is generic. It actually has good pharmacokinetic properties. So with this device that's in place, you easily place it in with a catheter. That is just simple catheterization. You slide introduce it behind it to push it in. There's a little nitinol area in it that actually will formulate into its nice little mini pretzel shape. Because of the osmotic component of this, it absorbs water. With the water going into the system, it starts to dissolve in the trospium and allows that trospium to actually elute out in a consistent type of fashion. So this trial is actually being undertaken now, and it's for spinal cord patients. They're in their phase 1. Just wanting to see a proof of concept. We're looking at spinal cord patients where we place it in the bladder, we keep it in for 42 days, testing urodynamics on beforehand and also midway through and at the end. And we're going to see, is there any carryover effect after that? So this trial should be ending soon. You may be hearing about it coming up. And then if it has a positive response, they would then open it up to that area. The last thing that I'll talk about for time is really using, this is a big thing, autologous Neo-bladder augmentation. And Dave actually, I think, was involved in this. I passed on this, smartly so. Autologous cells, one of the things that we tried to do is to regenerate our own cells. And back in the late 90s, this also hit big. Wow, you could recreate a bladder. We all get that. Why can't you make your own bladder? My bladder doesn't work. So they tried auto-augmentations, and at Michigan we tried that. Basically you peel the bladder muscle off, let the urothelium expand. The difficulty is over time it just contracted back. Didn't have a great success. So here they decided to use autologous cells using your bladder, expand that in the lab with bioengineered ability, but in order to help it there was a scaffolding, sort of a absorbable scaffolding that was put in place. You then would sew it onto the bladder as an augmentation, but then you would use actually omentum to cover over it to give it the blood supply, and then you would seal it in place with a little fibrin glue. Well, this made huge news in the early 2000s. Tony Atala, that's kind of his work. In 2006, Tony Atala showed actual clinical example here where he took patients, 7 of them, and you can see here, after doing this sort of implant, you can see the scaffold with the impregnated cells on it, the augmentation on top of it with the omentum. But he noted improved capacity, a little bit increased that area, and over time, it seemed to be doing very well. Well, and in fact, he showed nice histological specimens that even after 2.5 years, the actual area seemed to be a new bladder with new neovascularity and nerve growth into that area. And this made all the news. Well, as you know, when you try it in one little area, just like Dr. Zhao was doing it, you want others to replicate that. So they started to do a phase 2 trial in spina bifida patients. This is in the pediatric area. And they included a couple different hospitals in LA, the CHOP, Winston-Salem, and in Alabama. And what they ended to see at the end of 12 months, as you see over here, is there was no significant change in bladder capacity. So not a very positive trial. They also did an adult trial, and that's where I was asked to be part of it. I declined on that. Dave chose to be part of it. I was concerned that it's an interperitoneal operation, that if you have a leak, you're going to get peritonitis and you may have problems with it. The difference in the pediatric versus adult, pediatric, you really could take the omentum and cover the whole area. In the adult, I think you had a challenge to do that. And they need the blood supply to it to neovascularize that area. But as you can see here, they really had 2 responders, 2 partial responders, and 2 non-responders. And because of that, that trial kind of subsequently ended. So given sort of at least my area within the last 20-some years, you can see these are some of them that have done. Really only one of them has really made it in this time that I've been here, and that's with onabotulinum toxin A. And the thing about that I would encourage everyone here is that clinical medicine is fantastic. If you're a great clinician, do what you love. But the reality is research is the future. And I encourage you to get involved in research. Don't be disheartened if things don't work, because there's always other opportunities. And I would encourage you to always keep asking the question, why? What are the unmet needs? What have we done before? How can we improve? And if you always have that sort of mindset of thinking, don't get down in the dumps, because really the future is bright. the future, especially in neurogenic bladder and research, is bright because we have a lot to go in the future, and we need the people in this room that are doing it. And I'm glad that the Neurogenic Bladder Research Group is sort of a part of that. But thank you.